I am Katy Schuler from CRICO Strategies, and I'm joined by David Feldman, who is the Senior Vice President and Chief Medical Officer of Healthcare Risk Advisors and Chief Medical Officer for the Doctors Company. And Dr. Feldman was gracious to speak with us back in May about telehealth at the beginning of the pandemic so that we could see how it was impacting our industry, the medical professional liability insurers, the physicians, so that as a community we can come together and talk about how we were addressing the issue. So a lot has changed since then, Dr. Feldman, and I'd be curious to know what your thoughts are about telehealth at this point, as we now are about 9 months out from our initial conversation.
Yeah, great, Katie, and thanks so much for having me back for a brief update. A lot has changed, a lot more information is available, and I think it's worth sharing with our colleagues what some of those things are, and it will touch on a bunch of different areas. So let's just start going through this. The first thing to note, and this is information data from FairHealth. It's a pretty well-known organization that uses billing data, healthcare billing, to basically look at trends and so forth. There are a number of folks out there using billing data to be able to sort of show what's changing in the world of healthcare. It's obviously a big indicator to be able to look at. And here you could see, if you look at the number of claims, telehealth claims, 1 month at a time, they do this 1 month at a time, between September of 19 and September of 20, huge increase. Now, it's still only 5%. It's not, it's not the majority, not even close, but it's almost a 3,000% change. So it's a huge change. We never see those kinds of changes in healthcare, and this is not surprising to people. What's more interesting is, I guess, if you would ask the average, even physician, healthcare provider, nurse, what kind of claims are they? You might say, well, it's COVID, it must be respiratory, but it isn't. Most of this is in behavioral health, which sort of makes sense. If you think about the things that are most well suited to a non-in-person visit or virtual visit, behavioral health is like that. You don't typically do physical exams and so forth. So it makes sense that half of the visits that they're seeing in this billing data really are behavioral health related, and respiratory conditions really are sort of trailing behind somewhere. It's almost insignificant. So most of this is about behavioral health. Then some other data interesting to look at. This comes from the COVID-19 Healthcare Coalition, interesting group of healthcare related organizations, some actually in the Boston area and other parts of the country as well. And they actually looked at the impact of telehealth across the country. It's sort of fascinating to see where these patterns are the greatest. It looks like the Northeast. If you look at this, on the map, those with the darkest colors have the greatest change in monthly telehealth claims. And again, this is claims data sets similar to what FairHealth did, though it's a different organization. But you can see the Northeast has seen 30-fold, 50-fold increases in telehealth, a little less if you look in the western parts of the country. Whether those will catch up, whether they'll change, who knows? We know that since May now, a lot of the COVID disease has been out west as well. California's currently, at least, experiencing one of the worst problems. Whether we'll see more telehealth visits as a result of that remains to be seen, but one would think so. And here's some interesting data from Doximity, is a big telehealth provider. In September, they actually surveyed a bunch of their docs who provide telehealth services using their platform. And you can see that a lot of this is based on chronic illness. And many have said that one of the potential benefits, the biggest benefits of the telehealth increase, is for folks with chronic disease. Because the doctors and the patients know each other. It's not a one-off visit, so it's a little more comfortable. Typically, it's maintenance of blood pressure problems, diabetes, chronic illnesses that require check-ins now and then that really lend themselves to this. And by the same token, it's those very patients, certainly during a pandemic, who probably are at most at risk for problems should they develop COVID-19. So they're the ones that really want to stay away from going anywhere. And it sort of makes sense that those are the folks that would use this the most. But I think we're going to see more and more applications for this as we talk about remote monitoring and those kinds of things in the future. Here's some, and feel free to interrupt any time, Katie, if you think there are questions that our colleagues might want to be interested in related to this. Sure. Here's some more data from this study. And if you look, one of the most interesting things they found is there's lots of interest in understanding what communities, what different communities will or will not benefit from the whole telehealth explosion. And I've always said before, and I may have even said this in May, as we think about the balance for underserved communities, on the one hand, they may be the communities that don't have access. On the other hand, they could benefit most if they're the kinds of patients that can't afford to even get to their doctor's offices. They don't have cab fare or bus fare, or they're single parents and don't have childcare at home. They can't leave their house. So here's some interesting data that seems to suggest that although there are differences in the white, black, and Hispanic population when it comes to the ability to have a desktop or laptop, smartphone penetration, if you will, is pretty similar across all three demographics, which is encouraging. Whether there's broadband access, Wi-Fi access, that depends. I think if we're talking about rural versus urban areas, obviously that's going to be a little different. But I think this information is helpful in really understanding what populations are going to be able to benefit from this and what kinds of resources we as a country ought to be providing to be able to let those populations have the kind of access that they need. There's a very interesting study. This came out in August from New York City Health and Hospitals. Interesting, and they did this, I believe, prior to the pandemic. And this is a safety net population in the New York City area. 75% owned a cell phone. 65% were interested in telehealth, and most interestingly, 40% of those were over the age of 65. We often think of the elderly as those that have the hardest time with this, and some of them do, but there's still interest in their part, and some of that may, as we said before, be driven by the fact that those are the folks who may have the comorbidities that will keep them from wanting to go outside of their house during a pandemic, and may make it also more difficult even when there isn't a pandemic. You probably live in the greater Boston area. I'm in the Northeast as well, in New Jersey. In the winter, middle of the winter, nobody wants to go out of the house, especially older folks who are more sensitive to cold weather, who are worried about slipping on ice, that kind of thing. So these are the folks, I don't think we should discount them as potential users of this kind of technology and this ability to interact with the healthcare system in an easier way for them. I think that's kind of important. Here's some interesting data. Here again is some interesting data from this healthcare coalition, this COVID-19 healthcare coalition. They did this telehealth impact study, and here they again talked to doctors about what the physicians thought were the barriers. And the top one was, of course, lack of patient access to technology, digital literacy in patients, access to broadband, those kinds of things. But they do believe that a lot of this is going to be motivated by, again, chronic disease, medical management, care coordination, the kinds of things that might lend themselves to virtual visits. But here, one of the biggest challenges, again, is the reimbursement, right? We know that billing has been a big part of why this was never so popular beforehand. And of course, all that changed during the pandemic. Will that change as we go back? Already, as we know, there's been some changes with new suggested CMS regulations for 2021. Some of that is going to be maintained from the pandemic, some may not. We'll see. We're in the middle of all this. There's a lot of flux. But I think for physicians, it's not, if it's not viable from a business perspective, it probably won't happen, at least not as much as perhaps we'd like to. These are the three things I always talk about as the big three. That hasn't changed. There has been some interesting information about licensing. We've written about that actually on our Doctors Company website. There's some interesting articles about that are available to the public about licensing issues. It's one of those things that sort of dates way back. I mean, it's part of who our country is. We're a federalist society, so everything is state-based, and those of us in the malpractice world know that malpractice is very state-based, very different rules. I live in New Jersey, work in New York. I cross a couple of bridges to get there, and the rules are completely different, interestingly enough. So licensing is like that too for all professionals, doctors, nurses, and so forth. Many have complained that it just is not keeping up with the times, if you will. The military VA model is actually uniform across the country. If you're a physician licensed to work in one VA, you can work in another. Same thing with military hospitals. We'll look at the benefits during disasters. I remember even on 9/11 showing up at one of the hospitals in New York City. I was in Brooklyn. Nobody knew who I was. Nobody knew if I had a license or anything else. Now that's just within a city. Imagine going across state lines, and now there's been a lot of this, at least there was at the beginning of the pandemic. It makes it so much easier when there's one universal license. On the other hand, we know that physicians in particular are not so good at self-policing. There's lots of stories about doctors going from one place to the other who are really not the kind of doctors we want. And these are, of course, a minority of physicians, a vast minority, but it's those kinds of things that make people say we really ought to have each state do this so that there's some checks and balances on rogue doctors, if you will. Again, this is not such a huge problem, but every time this happens, people bring it up and say, well, maybe we ought to keep this state-based. I personally don't think this is going to change very easily. There is the Interstate Medical Licensure Compact, which is not a way to get a license more easily. It's just supposedly quicker. I haven't experienced it myself. There's now, I think we're getting close to 30 states in this, and all they do is to agree to honor another state's license. And with a letter and so forth, you get a regular license. It's not any kind of abbreviated license. A regular license in another state, you just get it more quickly. Still have to pay the fee, and those can be significant in the hundreds and hundreds of dollars, but it's a quicker way to get a license. I can't imagine if you were a doctor that wanted to do telehealth in tens of states, 20, 30, 40 states, to go through getting licenses in each one, even with the IMLC, is still going to be a great barrier. And if you talk to big companies that hire doctors to do this, this is exactly what they do. A lot of their administrative time is getting these doctors' licenses in every one of these states. All of this was obviously made easy during the pandemic. Some of that's still going on, but it's literally changing as we speak. Every state is different. It's almost impossible to keep up with all this unless you're constantly checking states' board websites. So it remains to be seen what happens with this. There are a couple of states, I believe New Jersey and Florida are two of them, that have special licenses for telemedicine. Those may be easier to get, maybe less expensive. I don't really know for sure the details. We may see more of that. But my personal feeling, this is just my feeling, I don't see that happening so quickly that there's going to all of a sudden be a national licensing for physicians or nurses for that matter, at least not so quickly. I think we're going to see some of these other things make it easier to get state licenses. So we'll see. I'll talk a little bit more about the HIPAA rules in a minute, and then the whole billing thing. We could talk for hours just on that. But these are really the three things that I think are the key factors that impact whether we do this or not as clinicians. And that hasn't changed. This is an interesting task force that was put together. This came out probably late summer, early fall. The Alliance for Connected Care, the NCQA, and the American Telemedicine Association got together and really came up with their thoughts on telehealth policy. These are the things that they recommended going forward if we want to continue benefiting, if we want our patients to benefit from this kind of modality. A uniform taxonomy. The NCQA, of course, is known for this with HEDIS measures and so forth. Do we have ways of standardizing how we measure quality when we're using this kind of modality? It's a very different way of seeing patients, and we ought to have some standardized way of looking at to make sure we're still providing high quality to our patients, even though we're using a different method of seeing them. And so some kind of uniform taxonomy around a lot of these things is probably going to be helpful if we're going to do a lot more of this. Again, the deficiencies in broadband technology and digital literacy are critical, and then recognizing its limitation. This is not for every encounter. There's no question about that. And I think doctors and nurses and others that provide healthcare are going to need to understand where this fits in their model. And I suspect, like everything else, there'll be some kind of hybrid. I don't think you're going to see a lot of, there are some now, but a lot of doctors only doing telemedicine and a lot of doctors never doing telemedicine, which is what the case was probably before. We're going to see more and more of this integration into almost every practice. Almost every specialty will probably use it one way or another. And this is what they think should be made permanent. All the things we've talked about, some will, some may not. The virtual prescribing, the state lines thing with the licenses, the first visit requirements and so forth. The one thing I think everybody agrees should probably go back to the way it was are the HIPAA protections. There's been a lot of talk about cybersecurity. I'm a plastic surgeon, and a lot of the things that plastic surgeons do are confidential and should remain that way. And we look at we talked before about the prevalence of behavioral health as part of telemedicine. We certainly want those conversations to be kept private and kept confidential. So having HIPAA protections as well as cybersecurity, I think everybody agrees, really people need to focus on. We often forget about that, or become sort of one of the things that's down the list. That should be on the top of the list if we're going to start doing this. And we all know that hackers are really going at it these days, looking for opportunities. So it's something we really ought to be taking seriously going forward. And I think finally, this is the part that I find most exciting, is all the innovations. Here's this Tyto Pro, this little device that you have sitting in your home if you're a mom with young kids. and your kid maybe has an ear infection, and here you can do a virtual visit where you can connect with your doctor, and there's a little thing you can put in your child's ear, and the doctor can look inside the patient's ear. Stethoscopes, cardiologists have been doing virtual health forever. If we think about the Holter monitors and rhythm event monitors that cardiologists have used for a long time, there's been an explosion in technology around cardiac health, these EKGs that you can put on your chest and that can be monitored remotely. Ultrasound's another device that's becoming ubiquitous in hospitals, in ambulatory care, and if you think about it, it's just taking it one step further to actually have an ultrasound that you can connect to your phone that a doctor or other person, an expert, can control remotely. So you can literally do an ultrasound-based exam, which in some cases, not all, but in some cases is better than a doctor's hands. So I think that's a positive thing. So all of this is sort of exploding now because now there's sort of an interest in this. And there's all sorts of great things. Again, a lot of this is cardiology based, all these EKG devices and rhythm strips. Stethoscopes have changed dramatically. I still have an old Littman stethoscope. As a plastic surgeon, I obviously had it in my coat. I don't think I use it very much, but still I had it. And now, of course, you have an ultrasound attached to it. It's a very different kind of instrument that provides so much more information. And much of that can be done remotely, as well as these other things. And there's all sorts of interesting things about personalized exercise therapy that can be done remotely, temperatures, of course, vital signs. We all know some of this is sort of ubiquitous now between Fitbits and Apple Watches. They're recording all this information. The real problem is going to be how doctors interpret all this and what are they going to do with this huge amount of information. That's really going to be an issue that we actually are going to be starting to look at ourselves at the Doctors Company, Healthcare Risk Advisors, to see if we can help figure out what to do with all this stuff. It's a huge amount of information that no one person can look at. The equivalent is sort of what these early warning systems are doing in hospitals, right? Taking all this data from a patient, from a bedside monitor that has vital signs, and then incorporating lab tests and all these other pieces of information from the medical record, and creating a score that warns a clinician your patient is going to deteriorate if you don't do something about it soon. No one person could possibly gather all that information and make those. It's just too much. Never mind the fact that these doctors and nurses are taking care of multiple patients. Now translate that into the outpatient area, and it's even more daunting to have a doctor who has a panel of multiple patients, all of them chronic conditions, and all these volumes of information coming into their office. There's just no way that any doctor is going to be able to look at all the information, him or herself, and be able to make heads or tails of it. They're going to need some help from machines or artificial intelligence. We don't know yet, but I think although there's a lot of potential in this, we need to be careful about not overwhelming physicians. And then as malpractice folks, we know that this can be an issue if, oh, why didn't the doctor see that? Well, that little piece of information was stuck inside volumes of things. There's no way that they could have possibly teased that out on their own. So I think that's something we have to be careful of going forward. And this is very cool stuff. I think there are these AI scribes that some of us have heard about. It's sort of the next step after a scribe that's in person, a virtual scribe, somebody listening, and then the AI scribe, a machine literally listening. And here's a telehealth company that not only does telehealth, but actually takes the conversations between the doctors and patients and creates a medical record for you. If we can take that into a regular medical record, that would be a boom, a huge boon for providers who, as we know, for the last number of years have complained bitterly about how they're spending pajama time entering records and so forth. Now that we've got more and more information to teach machines to do this with telehealth, can that be the entree into AI scribes for the rest of medicine? Time will tell, I guess. So that I think is, and this is sort of the AI scribe sort of path, if you will, all the way back from physicians making entries in paper charts to the electronic charts, in-person scribe, virtual scribe, AI scribe, and so forth. And I think that's an exciting thing that may come of this as well. That's my update for today, Katie.
That's a lot of information, David. Thank you very much.
Sure.
One thing that I was curious to ask you is when we spoke in May, you had shared some tips for using telehealth, and I'm wondering if those tips are the same. If would you offer different tips today? And there were things like, what's your website manner?
Right.
Wearing a white coat might not come across well on the screen, and some other things. So I'm just curious to know what you might have to say about that.
Yeah, I think most of those things have not really changed all that much. To be honest, there hasn't been any new insights that I've been able to gather. I will say that one of the things to think about is some of these rules. There was one of these things I think probably mentioned early on, these Roth rules that people use as a way to actually determine whether a patient was having respiratory problems, and it turns out it may not be a great that particular test, if you will, may not be a great predictor of COVID. So it's evolving. But I think some of the things we've talked about before, using some of this technology remotely to be able to replicate or even improve on a typical physical exam, I think is exciting. To add to the armamentarium of that website approach to seeing patients. So I think I mentioned Ottawa rules, which are these rules that were created really for emergency physicians to determine if a patient needed an x-ray or not. The same sort of things can be applied by a patient or family member when the doctor is remote to decide whether they need to be seen in person or have an x-ray and so forth. Those haven't changed. I think it's just the technology is exploding, and any help we can get, I think, is great, with the caveat, as I mentioned, about overloading ourselves with information.
Sure. It's interesting. I did have a virtual visit with my physician for sinus headaches. And one of the things I noticed when I went back and read my notes is that on the call, I was saying, oh, it's on this side, it's on this side, which is my left side. And then the notes in Zoom has a mirror image that you can select. I didn't know it was selected. And so they said my right side.
Wow.
So it was something that had to be corrected. And so it's easy to see that it's pretty easy to make a mistake in terms that could then be carried forward. And it was fixed, and that's obviously a very minor thing, but it's something that it's new technology for people, and they're still figuring it out. And I didn't know I had that setting. They didn't know I had that setting. So it's interesting.
Yeah, and that's why we've said, and we've really tried to emphasize to clinicians who are doing this, is not just taking your office and making it remote. Right? The workflow is different. Waiting rooms are not waiting rooms that we know of. And even things like this you wouldn't even think about, although frankly, it's one of the things we always worry about is wrong, attributing the wrong side, and that used to happen all the time. This just makes it worse because you don't know whether you're seeing the actual image or a reverse image, right? I mean, there's no way to be able to tell. So that's something that, physicians and clinicians that are doing this kind of thing need to have in their mind. What side is it that your pain is on, right? Because you can't really tell whether they're pointing to left or right.
Yep.
So excellent point. Excellent point.
And one final question for you. At the time we spoke in May, all three panelists were agreed in the fact that this is going to be a difficult thing to walk back. So patients and clinicians have essentially seen the benefit that telehealth can bring to them. And so it's going to be really difficult to take the regulations away that have expanded the use, take the billing away. And so do you feel that we're still in that phase where it's going to be difficult to walk it back and put restrictions back on it, or do you think it's going to stay?
I would say the longer it goes, the more likely it is that there will be, and there's already been some change, right? As you said before, CMS has already proposed rules for next year that do incorporate some of these things, not all of it. It used to be very restricted with CMS for Medicare. Now not so much, and Medicaid as well. So we already know that some of those have changed a little bit. Some of the things need to go back, the HIPAA regulations and so forth. I think the things that have been the most detrimental, that are going to be harder to walk back completely, are the billing pieces. The licensing thing we talked about, that's not as big of a problem for some people if they're in the same state. It doesn't really matter if it's just one state and now they've got some of their patients, like, I'm in the New York metropolitan area, so it's New York, New Jersey, and Connecticut where most of the patients are coming from. And while it's not easy, getting licenses in 3 states is at least something you can get your arms around. Not 20 or 30 states, not on your own. That's just crazy. So I think the licensing thing you can overcome for most people, not everybody. The billing thing is the big issue, and it looks like at least Medicare is taking the lead on not walking back all of it. That's a good sign, because usually what Medicare does, the other payers will follow it. Time will tell. But the more this continues, the more likely it is, and you've seen the surveys, patients really like this. And I think a lot of this, if it's used in the right format, I said this before, is very patient-centric. I've written some things in our own internal, in some of our publications at the Doctors Company about the lessons learned from this horrible experience about being patient-centric. This is one of them. And I said this probably in May, the idea of a waiting room. So you walk into this doctor's office, welcome to the waiting room, there's a TV in there. So what's the message? Have a seat, you're gonna be here for a while. That's not really patient-centric. I never understood that. It's sort of like, well, the doctor's time is worth more than the patient's time. And yes, doctors are busy, but patients are too. It just sends the wrong message. Even if it's some of it may be the facts, it just doesn't send the right message to patients. And now, my wife had a telemedicine visit, and she was in a waiting room, but she was sitting at home. She could be on her computer, so it wasn't as patient unfriendly, shall we say. Not to mention all the time that's wasted getting somewhere. I mean, living in the city to get to a doctor's appointment could take you an hour or two on mass transit or in your car, and then waiting in the waiting room, and then the return trip, it could cost you a whole day for a 15, 30-minute visit. It just doesn't seem very patient friendly. So I think that's something that I really hope that doctors and other healthcare providers will take to heart and think about how other things they do can be more patient friendly. That's not a bad thing.
Very true. Good point. And I guess a bonus question here would be about the liability risks. Have you seen any emerging risks come up? I know when we spoke in May, we had a lawyer on the phone who said that historically he didn't see a whole lot of telehealth. He saw EHR, but not telehealth. And if he did, they were usually behavior, mental health related, or radiology. So I'm wondering if you're seeing anything different at this point.
Yeah, well, Katy, because for your company, it's the same. Yeah. Everything is malpractice is a lagging indicator, right?
Yeah.
So it's going to take a long time, especially now when lawsuits are being delayed anyway, and plaintiffs' attorneys, hopefully and rightfully, are not bringing lawsuits against heroes, because healthcare providers have been heroes, no question. We looked just before this pandemic began earlier in 2020 at our malpractice experience. It's very few cases, a very small percentage. And actually, I looked at some data from the MPLA, which you know about, the former PIA, and there's a similar, very small number, though many of them were at diagnostic errors. So that's the one thing I would be careful about, is diagnostic errors. And a number of colleagues of mine have mentioned that they worry that a lot of things, or many of the things that they actually have managed to pick up on an exam they didn't expect to, on an in-person exam, and what's going to happen when they don't see the patient in person. I don't know the answer to that. I do know that there's interest in thinking about the things that you don't normally see when a patient comes to see you, that you do see when they're in their home, right?
Sure.
You see where the baby is, if they're in a baby crib, what their room looks. I mean, all these, it's different information. I don't know how all that's going to play out, so I would only urge my colleagues to be careful about using telemedicine in the most appropriate times. And I've said this to countless number of doctors over the last 6 to 9 months for a number of different reasons. Use your instincts. They usually will serve you well. If it just doesn't feel right, then don't do it. And if you're talking to a patient virtually and you just have this feeling that you're missing something, urge them to come in and see you or see somebody. And actually, I think patients will take it better knowing you've tried to do this virtually and you can't, and they may be more likely to actually go and see you or somebody, when if you just told them that off the bat, they might have been more apprehensive, worried about the pandemic or leaving the house, whatever it is. So I think diagnostic error is something we really want to be careful about. It remains to be seen what the legal landscape will look like when all is said and done with this explosion of telehealth. And that's about all we can say, and use your best judgment. Our mission is to advance the practice of good medicine. Practicing good medicine is using your instincts, and usually they'll serve you well. So
all good information, David. I really appreciate your time and your insights on this topic, and wish you a happy new year. So thank you very much. My
pleasure, Katy. Happy New Year to you, and a healthy one, and look forward to seeing you in 2021.
Sounds good. Thanks, David.
All right, take care.
Bye.
Bye.